Hello and welcome to this evening's UCSF alumni event, The History and Impact of Racism on Healthcare, Medicine, and Science. I'm Mario Praza, Executive Director of Alumni Relations. Before we start tonight's program, I would like to review a few housekeeping items to help you with your experience. There will be a Q&A towards the end of the panel discussion, but please feel free to submit a question at any time. To do so, use the Q&A box at the bottom of your screen. If you can, please keep your questions brief, and given the size of the audience and the number of questions that we've received and hopefully will receive tonight, we might not be able to answer everything, but we hope to offer an interesting conversation and answer as many questions as possible. Now, please join me in welcoming the host and moderator for tonight's program, Aimee Medeiros, Associate Professor of History of Health Sciences at UCSF.
Thank you, Mario. Before I begin, I'd like to start with a land acknowledgement. I want to recognize and show respect to the Ramaytush Ohlone peoples and their land and the land that they have stewarded for thousands of years. And so hopefully that helps as a grounding for us for today. I also want to welcome all of you who are coming into the Zoom call right now, and especially our esteemed panelists who are here with us this evening. I'm so excited to be here, and I am happy and honored to serve as the moderator. And please see me as the facilitator of this discussion, which means that I'm in a space to hopefully, my role is to help with the Q&A and also help with the discussion. We've received, I have been told we hit a new record in the amount of questions that we received for the panelists for today. So there's a lot of excitement about this program, and looking forward for the discussion that's coming that we'll be having. Also understanding as the moderator, we have condensed questions, we've combined questions. We also are using questions that were developed by developers of this program, and then also those that had submitted questions beforehand. So, so if you hear one of your questions or if something sounds familiar, that would probably be the question that you had submitted. So thank you all. And I think we're getting at a stable number here. So I want to start by introducing our panelists for today, or this evening, 5:30, and I'm looking outside my window and it looks dark, and I'm guessing it looks dark for most of you. So we'll say this evening. First, let me introduce Dr. Ayanna Bennet. Dr. Bennet is a resident alum of UCSF, and she is a pediatrician and the director of the Office of Health Equity within the San Francisco Department of Public Health. She leads a staff that implements multidisciplinary programs, data collection, and community engagement initiatives that advance equity as a priority in all aspects of the public health department's work. Also, I'd like to welcome Dr. Deanne Duncan. Dr. Duncan is a neuroscientist and the current Assistant Dean for Diversity and Learner Success in the UCSF Graduate Division. She is committed to biomedical, PhD, and postdoctoral education and training, and also diversity, equity, and inclusion, and is very passionate about inclusive excellence in the academy. Welcome, Dr. Duncan. And our third panelist for today is Dr. Karen Hill. She's class of '04, and also she let us know that she is one of, as many alum have heard before, she's you can stay for lifer, UCSFer. She has been here with UCSF in one capacity or another for 40 years. Her first job as a ward clerk started 40 years ago. So welcome, Dr. Hill. Dr. Hill is a doctoral prepared, board certified, advanced practice registered nurse with a specialty in environmental and occupational health and clinical training in adult, adolescent, and young adult health. An expert in workplace health and safety, Dr. Hill is exceptionally skilled in workforce assessment, engagement, and development. Her clinical capabilities span primary care, acute care, outpatient care, home health care transitions, and trauma-informed systems of care. She is experienced in the social determinants of health and health disparities and community engagement of underserved populations. So thank you, our panelists, for being with us this evening. Also, I want to say and just really emphasize, these are three of the great minds of diversity, equity, inclusion, and also the history of racism in healthcare, medicine, and the health sciences within our community. So we are really in this is so exciting to have you guys here. This is a real treat. So to frame our discussion for today, want to understand that we're going to be talking about racism. We're going to be using some terminology. Some people might be more comfortable with terminology than others. There might be questions that you have about terminology. Don't be afraid to ask. Definitely put them in the Q&A. There's no question too small and no question too big. We will try to address all questions, as Mario was saying earlier in the presentation or in our introduction. In doing so, though, we want to also understand that this discussion can take a lot out of you, can be emotional, and we thought it's just also, it brings up feelings often. And so with that, we thought that it would be best to start off with some community agreements to move forward in our discussion and then follow up Q&A. So first, we'd like to ask those that have made time to be here, and we thank you for being here, to be present. Try to refrain from checking email or doing other tasks as much as possible. And I know on Zoom, having attention spans can be limited, but if you can try to stay focused, I think that would really help us, and especially when it comes to Q&A. Also, assume best intentions. So when you hear some of the dialogue and you might be questioning things, understand that everyone comes in with different set of experiences and knowledge, and seek first to understand and assume best intentions are occurring in all interactions. Also, recognize that intent is different from impact, and that when someone says something and there might be a question around it, really focus on the fact that has been said or the observation that's been made, and not necessarily an attack, and please don't attack the person. Also, share gratitude and feedback. That's very helpful, and it's also especially helpful in these dialogues, especially as UCSF continues to engage in dialogues such as the history of racism in healthcare, medicine, and the sciences. And notice power dynamics. Be aware and cognizant that power shows up in many different ways, and sometimes in unexpected ways, and be aware of how this might be unconsciously operating and impacting individuals. And also, most importantly, and I am an alum as well, I'm a class of 12, these events are fantastic because they do really center on learning and growth. So if we can focus on that as our core principle moving forward, I think that can really be beneficial to our conversation. Okay, so with that being said, I'm hoping we can get started. The way in which we formatted this, like I said, received, I think, like about 20 questions or so, is that we've lumped them into certain categories, and we're going to spend some time with each category. So we're going to take a look at one of the most current topics, COVID-19. We'll talk a little bit about the history of harm, and then we'll also talk about diversity, equity, and inclusion a little bit more broadly, and in the health professions in particular. So I'm going to get started by starting, and this is, we were talking about this before the discussion started. This is an interesting experiment for me, given some of the panel discussions I've been in the past. You often have presenters present for 5 or 10 minutes, and then you get into the Q&A. And in this situation, we're gonna dive right in. So we're gonna start with some of the questions. So if one of your questions you want a little bit more of a background or a little bit more context, definitely feel comfortable asking that in the Q&A. So let me get started by asking the first question, which is about COVID, which is our first subject. And in particular, we want to talk a little bit about the relationship between the history of racism and healthcare medicine and the health sciences, and what we see taking place when it comes to the experiences of higher rates of morbidity and mortality in communities of color. So Black, Indigenous, and people of color communities, which is often referenced as BIPOC. Wondering if the panelists could speak a little bit too, and I'm going to ask Dr. Bennett to start us off in the conversation, and then if we can hear from Dr. Hill and then Dr. Duncan, a little bit about what might be happening about when it comes to these high rates. And also some of the media has talked a little bit about the vaccination rollout and vaccination trials that took place, and how some communities of color felt uncomfortable with some of these trials, and then also the vaccination itself. So if you could speak a little bit about that and to the history of racism in medicine and public health, I think that would be a good place to begin. So Dr. Bennett?
That just got bigger and bigger and bigger. So I don't know if I can briefly talk about that 4-hour-long topic, but Um, what is happening with COVID, I think for anybody who is operating in this space was not unexpected. Which group of people in the world of marginalized patients it would be maybe is somewhat up for debate sometimes, but it was always going to be like this because this is how we've structured our society. Bad things are concentrated on some groups and good things are concentrated in other groups, and we've designed it to function that way. So where people live, the legacy of segregation that says some people live under some conditions and other people live under better conditions. Most infections have some geographic component, the kind of houses people live in, whether they have to live with a lot of people or very few people, the kind of house you live in is very much related to almost any outbreak or infection. So all of the things that we've neglected to fix are relevant for how a disease spreads. And so we've unfortunately left it a lot of tinder to catch fire with. The history that goes behind some of the feelings that people have about questioning the medical care research or value of some of the things that have come out. That history is really rich in the history of harm is really rich in examples, and many of them are examples of things that happened in people's families because they are that widespread. It was not a few egregious things. It's not Tuskegee, it's Tuskegee plus 100 other things. Some which were quite mechanized and part of just the function of medicine, forced coercion in, oh my God, contraception of all kinds, not just sterilization. So that kind of history forces people to question because it's not a given that it's a positive. There actually has been enough reason to think it might not be a positive that it doesn't make any sense for people not to question. I think our job is to give them a framework in which to make sure that those questions are the right questions that will get them the information they need, that we can frame it in a way that says, now that you have the answers to those three things, you actually can be confident. So that kind of framing and thoughtfulness is really us, as I was talking about the other night, showing our trustworthiness. And that puts the onus on the system that has done the wrong thing. When your neighbor breaks your thing, your car, you're not necessarily going to let them borrow the next one unless they do quite a lot to show that something's different now. And we haven't done all that much to show that things are different. We just think they are. So we are probably going to have to put some effort into this. More?
Dr. Hill? No, that was great. Thank you.
There you go. Thank you so much, Dr. Bennett, for that. I'm just going to piggyback on that, that the fact that the pandemic, what it's done is demonstrated and exacerbated pre-existing social determinants of health and racism that have been really the foundation and the pillars of this country. And so what we do know is that where we live, work, and play impacts our health and our mental and physical health. I am seeing that some of the issues around how people of color are thinking about immunization, thinking about whether or not COVID is even a hoax. We still have folks, I have colleagues who are in the hospital with dying patients and they're still saying it's a hoax. They don't believe it. Is part of our messaging and communication in terms of how we have not been transparent. We haven't been transparent even about the atrocities with people of color and the things that happen. We all look to Tuskegee and we look to Henrietta Lacks, but there are hundreds of stories that we have not even been uncovered. And this is about history, but really we can talk about current state as well. You know, right now, women that have been in immunization camps are getting hysterectomies. We've got issues around folks who want fertility treatment and they're not being referred for fertility because there's a preconception and a bias that they can't afford it. A paper just came out talking about long-term care, that people of color who are in long-term care have higher rates of restraint, higher rates of infection. If they've been hospitalized and end up going from the skilled nursing to a hospital for an inpatient stay, they're more likely to actually go back to the hospital, and there are high rates of morbidity and mortality. And when they cross-check those with facilities that actually had people of color who were in leadership and decision-making positions, that the incidence of that kind of morbidity and mortality were reduced. So this is a current issue. And so folks would be remiss if they weren't hesitant and concerned about whether or not this vaccine is really something that should be for them. So I know for sure that one of the things that we need to think about is you have to have communication that is really directed for the populations, and it has to be delivered by people that are often from the population and that are speaking truth to power, for sure, and have experience. I'm complete.
Can I add one thing?
Mm-hmm.
I just want to clarify, because there's been a lot of talk about vaccine hesitancy in people of color, people of color communities. The vast majority of the anti-vaxxer movement that we've all been led to talk about is not about people of color. It's for the most part middle class and upper class white people. So there may be some vaccine hesitancy, but the vast majority of people of color who don't get their vaccines, it's because of structural barriers that have prevented them from having access. So we shouldn't feel okay that 80% of Black kids have got all their vaccines by kindergarten because it's a choice their parents made. It almost never is. So I just don't want us to get hung up on the idea that the problem exists in the communities, because that is, it's just a racist reflex. And the hesitancy around whether or not to participate in research, I think is a whole separate, I mean, it's a whole nother ball of wax that I don't necessarily think is worse now than it always is.
Okay, thank you for that. I'll say that I'm speaking from my 15 years of experience working at Glide Health Services in the Tenderloin, which was, we had a 95% minority population. And certainly it was a small population in N. We had about 5,000 patients. But we really had to do a lot of work around getting folks to get their immunizations. It was pre-COVID. And some of it was they just were concerned, didn't think it should happen. And we had to really, really do have conversations. We had to really educate and continue to do that. So I'm happy to hear that for COVID-19, that has not been the same experience. But for my work, I definitely was hearing folks that were very concerned about immunization and flat out wouldn't get them. And even in my own family, I have a brother who's quite smart, who, when I say, are you gonna get your flu shot? The first thing he says is, oh no, I don't want the flu. I don't want them giving me the flu. So, you know, we still have to continue to do educate.
It definitely exists as a problem. It definitely exists. I just don't want us to take the
we can't dwell on that. You're right.
Feeling we have about anti-vaxxers and attach it to this group, because it's a very different phenomenon.
Right.
I think that this is very interesting, and also even just the label of mistrust versus anti-vaxxers and who gets those labels and why, I think is also probably a really interesting point. And then also, Dr. Hill, you talked about Henrietta Lacks, who's often referenced in this in these discussions, and thinking about within UCSF community and our own history, and thinking of those that were experimented on, in particular. Plutonium experiments, and Elmer Allen, who was a film importer from Richmond, who was injected with plutonium. Henrietta Lacks is maybe exceptional a story in some regards, but in some ways it was part of the practice. So I think that, this is such an interesting and important, we could probably spend the whole hour on talking about
that.
the idea of mistrust and what does that mean, and how does agency and how does racism kind of plug into this idea of mistrust. But I also want to touch upon something that you had mentioned in your answer, Dr. Hill, when you were talking about how there is an importance of when there's community engagement, that there's also there's a representation that's there, that going into the community is something to unpack a little bit, and to think about best practices when it comes to trying to promote vaccination, also promoting positive health outcomes. And I'm wondering if you could talk a little bit more about interventions within maybe perhaps the COVID pandemic, but also interventions more broadly that have been used, that you have seen are very successful when it comes to reversing the poor health outcomes of BIPOC communities or BIPOC patients. So maybe talking about COVID, but maybe even taking it broader, if there's other examples from your rich experience that you had. Also, Dr. Bennet, if you could also speak to that too. So I will ask Dr. Hill to start, and then Dr. Bennet, if you could add, and then also Dr. Duncan, if you have something to contribute to when it comes to as well, maybe Deanne, if you could also speak a little bit of how, if Dr. Duncan can speak a little bit of how the idea of poor health outcomes could maybe frame it within BIPOC communities, or for BIPOC patients, could maybe frame basic science in a pretty innovative way.
So one of the things that I will say, certainly I don't have a vast experience of all over the world, but I will say that the things that have made a difference in my work in Los Angeles County and on the East Coast and Native American communities and in the TL and San Francisco were a couple of things, is actually really having people who mirror and look like the population that are coming in. So when people come into an organization to receive services, that they see themselves in that spot, in that space, that there are primary care providers, there's the admin people, that's multicultural, not just, I don't want us to just get stuck on Black, white, Latinx, Mexican, all of that. We have to have a diversity of all kinds of people. And those are things that are important. I also think that what's important in terms of going into communities is that you meet people where they are, and that you respect their lived experience, and you be transparent and not judgmental about their concern, and to use techniques that we have all trained. Everybody on this call is familiar with motivational interviewing and just taking baby steps. Those are the things that make a difference. And then making the care accessible. It can't be hard to get it. It can't, telephone calls and appointments and driving all over. Those are the things that make it easier for people to decide that they really want to engage and that they trust you. The other thing I want to say is that we have to stand on our word. If we're going to say we're going to do something, then we actually really have to do it. And we have to do it in the context of keeping cultural humility and diversity inclusion at the center of what we do. So when we think about going out and trying to get folks to be more interested in safety measures around COVID-19, or getting a vaccine, or even just regular health care, we then have to see it through the lens of historical violence and of historical racism, and really modify and customize our approaches so that we let folks know that we understand and we see and hear them, for sure. I'm complete.
All that. I will not repeat any of that, but all of those things are things that I would very much love to see happen more often. I'm going to step back and do a little bit more framework as the alternative. If people can arrive with the assumption that they have bias and that their job is to manage it, I think we would all do much better.
Yes.
So there are the depth of research on how to manage it is not quite there yet, but we do know some things. So all of the things that that you need to do to follow cultural humility as a framework, those are the same things that would allow you to follow the recommendations about bias. So individuating, making people not members of their group, but actually full and complete people. That is the same thing you do with communities. You don't use the collection of television images you've had about Native Americans to decide what's going to happen in the Native American community that you're now encountering. The same thing for all the other communities. We are a very segregated country. The lack of segregation is quite recent for many people. Their kids are in diverse environments, but they themselves did not grow up in it. So without any actual lived experience with these groups of people, it is really hard not to have your mind pull up a bunch of things you do know, which is probably TV shows and stuff that wasn't necessarily complimentary or very accurate. So question your own knowledge, question whether or not you have enough knowledge to do what you're trying to do, and then question. Just ask people, learn something about the place where you live. Don't go to a clinic in a poor community, never having gone to any other street. So those kinds of things where you accept a void in your own knowledge, something will fill that void. I call racism the answer your community gives you when you don't know anything. So I don't know how that person will treat me. Well, racism has given you an answer. What color is he? What does he look like? But that's not effective. And it's certainly not something that should exist in medical care. So we have to be much more conscious and take this as it's almost a disability we're all going to have to manage, but it is. It's just a thing we all share that's not very good, but we all need to manage it and admit that it's there.
I would agree. We have to question ourselves. We have to,
Oh, we lost you. You're on mute. Can you unmute yourself, Dr. Hill?
Yeah. I do this work. I still have to question myself to make sure what lens, what framework, is there some kind of bias that I'm bringing to it when I make a judgment, even when I see somebody or think about something. So I think you're right. It's an iterative process and it's ongoing because innately as humans, we like to categorize and judge. We do that. So we have to be very careful. I'm done.
And Aimee, can you repeat the question that you would like me to answer?
Yeah, so I was wondering and thinking about the basic health sciences. I'm wondering a little bit about how understanding and recognition of poor health outcomes or of just the history of racism in medicine and healthcare could perhaps serve as a framework for that type of research. Often what I hear is that the laboratory is so separate from these discussions. Do you find that to be the case, or is there a way in which we could maybe reimagine this framework for the basic health sciences that ultimately inform the clinical care that and also the public health measures that we see being developed?
Great. Thank you so much for repeating the question for me. Yes, I absolutely do see that there is this separation between the basic science laboratories as well versus clinical care. And I think that they definitely needed to go more hand in hand. And one of the things that I think about pretty often, and I know that we're making some strides in that in the work that we're doing here at UCSF, is really framing the conversation, the history of racism, the history of racism in science as a foundational principle to for our basic science PhD students to really land on as they're building their biological knowledge about research and disease. I think it'll make the work a lot more powerful, the research more powerful. And the other thing that I will add is another level of separation is really having basic science researchers go back into the communities, you know, and really educate the communities about some of the research that's being done at institutions like UCSF, because I think that is something that also needs to happen in addition to some of the clinical care work that Doctors Hill and Dr. Bennett also referred to in some of their answers. So I think it would be a powerful move to kind of add that element to the curriculum moving forward for our for individuals who are engaging in basic science research.
I'm going to add on to what you've just talked about, Dr. Duncan. I was working with the Center for Youth Wellness in the Bayview Hunters Point, and we actually brought the Henrietta Lacks family out and had a public forum. And I brought UCSF researchers down, and we had an open forum with the family and the community to talk about work that was happening at UCSF, to talk about the science, to talk about some of the history. And to your point, Dr. Duncan, that was so well received by community. The things that we heard is that folks come in our community, they give us a $5 gift card, they want us to participate in some kind of study, and then we don't hear anything about the study. We never know what happens and how does it benefit our community. So I think you're right, coming back into the community, getting folks from community engaged in research, that it can really be helpful for them, and they can that they have agency over their lives, and that we are concerned about and want to hear from them is powerful. So thank you for bringing that point up. I appreciate that.
It's a great example of, and we should do that every year. The fact that that's a one event and done, it feels like it might be something that's that should be considered as an example of what we can continue to do in the type of programming. And with that being said, I'm wondering if there are certain examples that you might want to share with the group about how, and this is kind of collapsing a few of the questions that we received before the event, but is there ways in which you have been a part of, or you could imagine, so either or, real examples are always helpful, the way in which we can address the history of racism in medicine and help it inform some of the current practices, acknowledge the way it informs the current practices in an effort to try to break that cycle and to really have a critical dialogue with multiple communities, right? Not within the community and then within the UCSF, I think of multiple communities and asking this question. So my question for you, because that was kind of jumbled and I apologize, is can you think of some examples that either you have helped develop? The Henrietta Lacks example is exactly what I'm talking about, but opportunities where in which better understanding or better acknowledging how can we acknowledge that history as we move forward in both basic health science research and in clinical care and our practices. I'm curious to hear more. And I will ask, since the Lacks story was so great, if you have other examples you'd like to share with us, Dr. Hill, and then also hearing maybe a little bit, not little, but a lot about what's happening in the San Francisco Department of Public Health would be fantastic, Dr. Bennett. And then also Dr. Duncan, you had mentioned about how there is this need to make a deeper connection or to build those bridges. And maybe if you can speak a little bit more about what are some of the programs that are in place intended to do that.
Well, I'll start because I am not aware. I suspect they're happening in pockets where folks are really trying to bridge this work. One of the things I think that would make a really big difference, and it would have made a huge difference in my own education, is that we bring racism and the effects in all aspects of the lives of people who live in this country and across the world into our educational systems. I didn't learn anything about this in nursing school. I didn't learn anything about this in high school. Frankly, I didn't learn anything about this in graduate school until way into the, I studied issues of race and trauma in my doctoral program. So I think the first place we need to do, and it would serve two goals, is it would help to take some of the angst out of the conversation. It would normalize it. It would sort of acknowledge that this has been the history of this country, that we have to talk about it and we have to own it, and that we are now going to make changes about it. So I don't know what's happening around the country. Maybe my other colleagues can say that. I do know what's missing is that we're not talking about the historical missteps that have happened with people of color in this country. And that is a reckoning, and we need to start right at the beginning when we start educating folks.
Dr. Bennett, thank you, Dr. Hill.
I think we have made some, there are examples of inroads. I think the conversations in medical schools and graduate schools that are happening around structural competency. Do you actually know enough about the structure of your own society, which includes racism really deeply, in order to be able to make reasonable decisions and reasonable relationships with people who do know that history? I am continually shocked by how little some people have been told about this. I've had colleagues who had no idea what redlining was. I've had colleagues who assumed that segregation only occurred in the South. There are tons of misconceptions. And my supposition for them is that if you don't have a reason, the entire history of redlining, lots of other things, for why Black people live in the communities they do, what is your explanation? What did you make up to explain that phenomenon to yourself? There's a good chance that that was not either accurate or complimentary or helpful to you in interacting with those communities. So people getting that structural competence, learning the history that maybe the patient already knows and you don't know, filling in those gaps, I think is really important. And I think we've started to do that. Part of the problem is that racism as a valid topic to study is not that long. the kind of length of academic respect for it as a phenomenon is only a few decades old. Lots has happened in that time. Lots has been documented. A lot of things have been elucidated, and there's a lot of theory that's happening that is really useful, but it's not that long ago. So it always takes things time to move from the sphere of academia and research into something we can practice with, but we are making that change.
So I'm just going to
for
sorry, go ahead.
Thank you. And I'll say for the basic science side of things, again, a little bit of work is being done to really engage with the community. One of the programs that I oversee in my line of work, I think it was a couple years ago, I took some of our students. This program is dedicated to support underrepresented students in their PhDs in the sciences here at UCSF. And one of the students actually wanted to go to Bayview Hunter Point to learn about how the science that was committed in that area or conducted in that area directly influenced the Black population in that area and the health outcomes of the individuals that lived there. And that was a really powerful moment for the students to really see how, again, the science that they're doing in their labs, we directly learned the history of from one of the organizations down in that area, and how that really impacted health outcomes and well-being of individuals. And so I think if we can continue to have those type of programs and those type of opportunities and really elevate it and also take the lessons learned from that so that we can share it with graduate programs and other training environments, I think that will really start to shift the conversation and again, lead to the integrations that we're talking about here today. So thank you.
You know, the only thing I was going to add, and I apologize for cutting you off, Dr. Duncan, is that, and I have certainly benefited from programs that were really trying to improve diversity in the sciences. UCSF's Minority Training Cancer Control Research program with Renus Pasic. I'm a graduate of that program. I know that UCSF is really doing a lot of work in the School of Nursing to recruit diverse nurses. But one of the things that I think we have to be really mindful of, and that this is still true, is that once we recruit people, we have to make an environment for them to really feel accepted and needed. And that piece, I think, still has to be, there has to be a lot of work around that. There still has to be work around the fact that, you know, if I'm a woman of color and I have a doctorate degree, that is a respected degree as if it is with my white colleague. And then if I'm accepted in an organization. So we still have some work to do around making people of color feel included, their voices are valued, and that they don't have to necessarily conform to be whatever we conceive academia to look like. I'm not sure if I'm saying this correctly. I just feel like it can be very, very difficult to live in the medical scientific world if you are an individual of color. We don't have a lot of mentors. You have to be very careful and mindful of how you navigate. So there's still a lot of, there are things happening, but there's still a lot of work to be done.
That was great. In thinking about all of the questions that we received and looking at our time, I want to be mindful and respectful of people's time. It was really interesting. We got very big questions before the event. Things that people asked were referencing reports where it was stated that there was low numbers of a lack of diversity in the health professions, a lack of diversity in medical and health science education. So we had some really big questions. And then we also had some more very specific or very strategic in a way of what can I do, more kind of interpersonal. And we haven't really spent a lot of time with those very specific questions. So I do want to ask you, and you can bring it big if you want to talk about bigger forces with this specific example or specific questions, or if you want to talk very strategically about, hey, this is something that you can do. But questions that we also received beyond, you know, tell me all about the history of segregation in healthcare. We also received questions like, I am currently in a program where there aren't any underrepresented minorities. How do we get these conversations going when no one seems to care? Or so I think that's a really interesting question. So for those that are joining us today, thinking about, you know, some of these interpersonal things that maybe they could do, or just things that they see every day that they want to address in some way, I'm wondering if you could speak a little bit to that, and you can use that example, or like I said, you can take that example and go a little bit bigger, or even go in a totally different direction. I'm going to leave it up to you guys. You guys are experts, but I just thought it was a really interesting question that was offered to us. And so I'm going to ask if Dr. Duncan can start our conversation, in large part because of the lead role that she takes in education and training in the graduate division, especially when it comes to diversity, equity, inclusion. And then if Dr. Bennett could then follow, and then Dr. Hill.
Thank you. Yeah, I saw that question. I was like, my mind was just percolating with so many ideas. I mean, one of the things that I often think about, and I actually had a conversation today about it with someone else. I often tell individuals to really find people that are like-minded to them. So in terms of, you know, when we talk about being in a program where no one seems to care, I would say find others who care about what you're interested in related to diversity, equity, inclusion, and build allyship and build morale that way. And I think once you have a critical mass with individuals, then you can bring it back and really have an intentional conversation with those that may be perceived as not caring. You can have some more support in that area, because I often see some of the students that I work with, they're doing a lot of these things alone, and that can be just mentally exhausting. It impacts their well-being, it impacts their success, and that's not why they came to Ucsf. They came here to get their education and to get their degrees. And so the more people that you have behind you that are like-minded, that you can have some support, the better. And then the other thing is also, it's connected to that too, is also finding other affinity group communities, again, where you can still dialogue, have a place of support, have mentorship, have allyship. And this can be between students and other trainees on campus. I know that we've been doing a lot of work at UCSF to get basic science students into more connected to our health science, our professional students, just because we're here at the same campus, having the similar experiences. So again, bridging the gap by having conversations and not necessarily working in silos, I think is something that is a really essential part of this conversation. So thank you.
I love all of that. It definitely is lonely work, and it is too hard to do by yourself. On that same vein, I think my advice would be, I have a couple things. First, you are not going to fix it. There aren't going to be 12 people next year because you did something this year. So figuring out, how do you think this is going to happen? People often, I think we very often, especially around this topic, concentrate on the emotions because they are so strong. But getting more people in is not going to happen because people have an emotional reaction and now care. They actually have to do something. So recruitment has to change, admission criteria have to change, something has to change. And then figuring out what those things are and picking a target that you want to see move can give you a sense that you are actually, and in reality, move the ball forward in a way that is reasonable, that you can be proud of, that actually has a practical impact on what happens later, but isn't you picking up the entire ball of racism and trying to fix it, because that's not possible, and you're moving an institution. Institutions are huge. So picking a goal that you think is realistic and modest, finding some coworkers, friends, other students to join you in that goal, and making it very specific what you plan to achieve. Specific asks often get answered. Vague senses of you guys should feel differently do not. So being very practical about what you want, I think, can make it much more satisfying and less of a burden.
Well, thank you. I would agree with all of that. And I'm even smaller than that. So I will talk about, I'm a storyteller, so I'll talk about, what I chose to do and what I have done in my career, and what helped me is mentoring and coaching and suggesting to other people of color. I'm a nurse. I love nursing. So I'm trying to recruit people into nursing and dental and medical and healthcare, because I think healthcare is important, but often just planting the seed and teaching people how to do it. They can navigate. And then if they choose to follow your path, to be there, if they need help to work through a thing, because that's part of it. I would agree with you, Dr. Bennett, it is lonely work. And sometimes you have to, it's a lonely path. Sometimes you have to have people that you can call on that understand what you were going through. And so for me, my work at Glide and my work in my consulting work is to suggest to other folks, have you thought about an advanced degree? Have you thought about going to nursing or medical school? And this is how you can do it. And there is money that you can find to do this. So I would agree with all that, finding like-minded people, agreeing to be mentors and coaches, and help folks navigate those very, very difficult waters of professional life and of healthcare, that's for sure.
And may I add one more thing? Okay, thank you. I just wanted to also stress something that you said earlier, Dr. Hill, about ensuring that if we're going to recruit historically underrepresented, historically marginalized students, staff, patients, faculty, et cetera, that we have the support structures in place at these organizations to really take care of them. And I really stress that that's one of my core values in the work that I do, and really thinking about how that fits in tandem with, you know, outreach initiatives. I know, Dr. Bennett, you just talked about it a little bit, to have tangible goals and things like that, and for there to be some very concrete actions taken around that. So I just wanted to really reinforce this notion for the audience. And the second thing I'll just add is really thinking about individuals in general and any organization should really look to the folks that are in multicultural resource centers who do diversity, equity, inclusion work, anti-racism on campus, because a lot of times we're the gatekeepers to knowing how to fix these challenges, and we're really looking to others to come to us and to work with us. You know, we want allyship. We need more support in this area to really take care of our constituents here and to ensure that we have an equitable, inclusive environment. So that's my little shameless plug on that.
Good.
It's a fantastic point. Thank you. And that segues to some of the questions that we've received during the program this evening. And I want to start with one that I think that Dr. Duncan can get us started in the discussion, and then perhaps Dr. Bennett and then Dr. Hill can, or Dr. Hill and then Dr. Bennett. Let's go the opposite way, because the last time we went that way. Shake it up a little bit. All right, so I love this question. I can't wait to ask it. This is a great question. All right. We know that the lack of basic clinical science research that includes BIPOC creates biased scientific outcomes. How do we convince these communities that they will be treated with respect and their contribution to research is valued and important?
Yeah, that's a great question. I personally think it's connected back to the sentiment that I just said, in terms of it's connected back to outreach, but then also ensuring that your environments in which, you know, you're asking people to engage in or do research in, asking students to do research in, is for them. You're creating an environment where you're going to allow individuals to come to campus, feel valued, feel respected, feel celebrated with all of their lived experience, all of their identities, and that is a part of the culture, right? And it's a part of what they do, and it really informs the way that they move and shake when they're conducting their research. So I think if institutions, organizations really do a deeper dive into figuring out what that looks like, and again, relying on individuals who do this type of work full time on the campuses, I think then you can create some strategies that you can then communicate to these populations. That's personally what I'm thinking right now. Off the top of my head, I probably have to think about it a little bit more, but I'd love to hear what Dr. Bennett and Dr. Hill have to say about it too.
So I agree with everything that you said. I guess what I want to say is we have to close that loop, meaning think of sort of participatory research where folks that are in the research are actually part of the research. If there's a paper, they get to participate on part of that. They know what the findings are, that we actually conduct research, but we teach and engage and demonstrate how them being involved in research changes the lives, not only for them and folks coming after them. I think that that's really the missing piece, is to that closed loop, and of really not having people in a bowl where you're just getting what you need and then you move away. So that's what I would say is how we do that.
I'll be quick because everything good has been said. One little thing. One, what is the value you're giving them? There should be an exchange here. And that may be information about their body, their life, their community. It doesn't have to be a Safeway gift card. It can actually be something that you feel is substantial. And also having people involved in the research who can help make sure that as you're recruiting, you're doing things in a way that are welcoming to the people you're talking about. So we've started a process at the department because we suffer from the same history as UCSF does of doing research in a way that is offensive and has not been respectful, of screening proposals that want to use the clinic or use public health resources to see if they're equitable and actually ask some questions. And I've pushed back and asked some questions. Is the risk being equal here? Are the only people taking part in this poor people of color? Is there anybody else taking the risk of the intervention that you want to test? Is there anyone else who has had a say in how this goes? Is your flyer at a college level that probably no one understands? So those things that show respect for the people you're talking about and make sure that they're part of a larger community, not a target. So if they're part of the research, not a target of the research, I think you'll have much better outcomes and people respond better.
Thank you. Great responses. And thinking about how well you guys are able to encapsulate like big ideas with very strategic advice, it's just very valuable. And with that, I'd like to ask our final question for this evening, which is, if you could recommend more than one, but I'd say maybe one bold step that you would like to see San Francisco or UCSF or both, or a medical institution you might think of that you have in mind, what they could do, any of those or all of the above could do, given our current needs and resources to advance racial equality. And I'm going to go in order of how I see you on my screen, which is Dr. Bennett, Dr. Duncan, and then Dr. Hill. Oh, you are on mute, Dr. Bennett.
I have this little idea I've always wanted, and nobody thinks it's that interesting. UCSF raises an incredible amount of money. If they would just declare that 1% of all the money they raised would go back into the community, they would be enormous contributors to the community. So 1%. And I don't think donors would be so offended that we're going to spend 1% of any donation you give us in the community in the form of community-based grants. Just do it. It's not that complicated. I think it'll make you look great.
Mine's along the same line. I would say invest in resources. I know diversity, equity, inclusion, anti-racism work is quite rewarding as well as challenging, and it's usually relegated to a few individuals on campus. Let's invest our resources to really take care of our large amount of constituency. So just like Dr. Bennett said, maybe that another 1% can go back to more resources for our organization. So that's my answer. Thank you.
And I would say that everything starts from leadership. And so I think that one of the things that UCSF needs to do across the board is to make diversity, equity, and inclusion really visible in their executive leadership. I think so, rather than, have folks, at the lower rungs, that we need to, in the C-suite, have diversity there. And that would be a really important step and voice to say, so that people can see themselves in the organization and that we can lead by example.
Fabulous, thank you. I'm hearing let's wrap. I'm seeing that in our chat of our prompt, and I'm not sure if that's really me that's supposed to be doing that. I think that's Mario. So I'm gonna pass it off to Mario. I just want to say thank you so much. I have so much gratitude for this event tonight. So thank you for inviting me, and also thank you for letting me moderate this panel.
Thank you so much to all of our panelists this evening. We hope to continue this conversation at a future alumni event, so be on the lookout for more events on this topic. It's a huge conversation and we hope to continue. The recording for tonight's event will be sent out later this week, so please share widely as well so you can share with other colleagues and alums. I hope you can join us for one of our upcoming events. We have an event next Tuesday, another alumni author conversation with UCSF alumna Diana Hendel in conversation with Mark Larrett, the President and Chief Executive Officer of UCSF Health, on her two most recent books, Responsible, a memoir, and her recently published Why Cope When You Can Heal, How Healthcare Heroes of COVID-19 Can Recover from PTSD. It's another interesting conversation next Tuesday. I hope you can join us. So have a great evening and good night, everyone.